Alright, you guys, welcome back to another video lesson from ICU Advantage. And this lesson is going to be another lesson in our series that we're doing covering various ICU drips. And in this lesson, we're going to be talking about the vasodilators. But before we begin, if this is your first time to our channel and watching one of our videos, we do invite you to subscribe to our channel below. Make sure, though, you hit that bell notification icon. That way you'll be notified as soon as our new lessons become available to you. As always, we really value your subscriptions, the likes, and the comments that you guys leave. It really goes a long way to help support this channel, and for that, I do want to thank you guys. And for those of you who don't know, my name is Eddie Watson, and this is ICU Advantage. Alright, so let's get into talking about these vasodilators. And so to start out, let's really talk about what exactly are vasodilators. Essentially, vasodilators are a class of drugs that relax smooth muscle in blood vessels. And so really what this means is that it's going to cause the vessels to dilate out. And there really are multiple ways in which the drugs can perform this action, which we're going to talk about here. So when we classify our vasodilators, they're going to be classified either based on their site of action or their mechanism of action. So now our vasodilators can have an effect on either arterial or venous vessels, or sometimes even a combination of both. Now, most of the vasodilators that we're going to deal with are going to be what we call mixed vasodilators. So essentially they're going to have an effect on both the arterial and venous vessels. Now, depending on the drug, some might have more of an effect on arteries versus veins, but it is good to know that there are a couple that are much more selective for one over the other. So now if we talk about our arterial dilators, these are going to be ones that are commonly used to treat either systemic or pulmonary hypertension, heart failure, and angina. And so really the process that's happening here is we have dilation of the arterial vessels. And so this means that we're going to have a decreased afterload, or what we call SVR, and thus this means we're going to have a reduced arterial pressure. If you want to understand this more, I am going to link up above to a lesson that we have in the hemodynamics series covering cardiac output. But for the purposes of this lesson, when we look at a reduction in afterload, that this is actually going to improve cardiac output by having that afterload reduced. And this is because it's going to be easier for the heart to beat against a lower blood pressure. And so by having this increased cardiac output, this is going to lead to ultimately a decrease in preload, less blood backing up in our patients. Therefore, this can be beneficial in patients with heart failure. Now again, because it's easier for the heart to beat against a lower blood pressure, this is also going to decrease the oxygen demand of the heart, which is going to be beneficial in those patients with angina. Now, when we look at the venous dilators, there's really two primary functions in treating cardiovascular disorders that we really care about. And this is going to be primarily for patients with angina and edema. So what happens here with angina is we have a reduced venous pressure. And so this means that we have a reduced preload. And as a result of the reduced preload, we're going to see a decreased cardiac output. And the reason for this is because by having a decreased preload, it means we're going to have decreased stretch in the ventricle. So remember, think back to Frank Starling. And this is ultimately going to decrease our stroke volume, which is going to have an impact on a decreased cardiac output. As a result of all this, you're also going to have a decreased arterial pressure. So this is useful in patients who have angina because they're going to be reducing the workload of the heart. So now in the case of edema, we're going to again have reduced venous pressure. And so this means that we're going to have reduced capillary hydrostatic pressure. So essentially there's going to be less pressure being exerted within the capillary beds. And this is going to lead to a reduction in edema. So these are the benefits when looking at either strictly arterial or strictly venous dilation. Like I said, though, the majority of the medications are actually going to have a mixed effect on both the arterial and venous side. And so now, if we look at mechanism of action, it's actually more common to classify these medications based on this mechanism of action. Now, there are many classes to these medications and their mechanism of action, so I'm going to go ahead and list them all out for you just so you have an awareness of them, but we're only going to talk about some of them. The first is what we call alpha adrenoceptor antagonist, or essentially alpha blocker. The next is going to be the angiotensin converting enzyme, or ACE inhibitor. Next is going to be the angiotensin receptor blockers, more commonly referred to as ARBs. Next we have Beta-1 adrenoceptor antagonist, or beta blockers. Then we have the Beta-2 adrenoceptor agonist, or Beta-2 agonist. Then we have calcium channel blockers. We have direct-acting vasodilators, endothelin receptor antagonist, nitrodilators, phosphodiesterase inhibitors, potassium channel openers, and renin inhibitors. So as you can see, a pretty extensive list of classes when we look at these medications by mechanism of action, although the majority of these you probably have heard before and you're used to a lot of the medications that fall within these classes. Like I said though, for the purpose of this lesson, a lot of these aren't medications that are specific ICU type of medications or medications that we'd be giving in drip form to our patients. Therefore, we're only going to focus on a select number of these classes and talk about some of the medications that are within each class. Now, don't necessarily worry about memorizing this list, but knowing what the class is will help you to understand what the effect is that you're going to see from that medication. All right, so with that said, let's go ahead and talk about the first class that we're going to be talking about here, and this is the angiotensin converting enzyme, or ACE inhibitor. Now, there's not much that I'm really going to say about this one because it's not really commonly used as continuous IV. So I almost wasn't going to include this in the lesson, but I think it is important to have an awareness of some of these medications that you could possibly see. And really, when it comes to the IV form of an ACE inhibitor, we're talking about a medication called enalapril. And the only thing I'm really going to cover here is in the off chance that you do see this medication given, the typical dose range that you're going to see is from 0.25 to 0.5 milligrams per hour. Like I said, not very common. You probably aren't going to come across this one. All right, so now moving on to the next class, this is going to be our Beta-1 adrenoceptor antagonist, or what we call beta blocker. Now, our IV beta blockers are not typically going to be used solely for vasodilation effects, but certainly at times they can be. And so for this class, what these are competitive antagonists for beta-1 receptor sites. And we're going to see the effects of this in the heart with a decreased heart rate and contractility, as well as in the blood vessels with smooth muscle relaxation. Now for our medications, there's two different ones that I want to talk about. The first one is called esmolol, and the other one is called labetalol. So to start with esmolol, we're typically going to find this in a mixture of 2,500 milligrams and 250 mLs. And our typical dose is going to be from 50 to 300 micrograms per kilogram per minute. Our onset is usually 2 to 5 minutes, and this one we'll be looking to titrate every 5 minutes. So now when we talk about labetalol, we're typically going to find this in a mixture of 500 milligrams and 250 mLs. And our typical dose is going to be 2 to 8 milligrams per minute. Now, it is important to know that we don't want to exceed a total dose of 300 milligrams. From there, our onset is again 2 to 5 minutes. And this one we're typically going to titrate every 10 minutes. Now, like I said, these aren't typically used solely as vasodilators, and you're typically going to see these used to reduce a patient's heart rate. All right, so now moving on, let's talk about our Beta2 adrenoceptor agonist, or our Beta2 agonist. Now, these medications are, again, not typically used for their vasodilatory effects, but it is good to know with these medications that they can have this effect. Now, the medications in this class work on the Beta2 receptors, and they work as agonists on those receptors. Now, this has effects both in blood vessels, as well as in our respiratory airway, but the main thing that we want to focus on is this effect in blood vessels. And by activating the beta-2 receptors, that this is going to promote smooth muscle relaxation. Now there's two main medications that I want to talk about real quickly in this class. Now this is going to be our dobutamine, also trade name of Dobutrex, as well as isoproterenol, which is trade name is Isopril. Now, I'm actually not going to talk much about these two because they are going to be covered in another lesson, but I do want to make mention of them here because, again, they are medications that you're going to end up coming across. So in the case of dobutamine, this is going to be primarily used in heart failure to increase contraction, whereas isoproterenol is primarily used in the treatment of bradycardia. And our typical dose range for dobutamine is going to be 2 to 20 micrograms per kilogram per minute. And for isoproterenol, the typical dose is 2 to 20 micrograms per minute. All right, moving on, let's talk about our calcium channel blockers. Now, these medications work by binding to vascular calcium channels, and this prevents an influx of calcium into smooth muscle cells. And so since we know that calcium stimulates contraction, by preventing this influx of calcium, we're actually going to be causing smooth muscle relaxation. Now, our calcium channel blockers are going to have a primary effect on arterial vessels with minimal effect on venous vessels. Now, the most common of these calcium channel blockers that we're going to use for vasodilation is going to be a medication called nicardipine or cardine. Now, typically we're going to find this in a bag of 25 milligrams and 250 mLs. And our dose for cardine is going to be 5 to 15 milligrams per hour. It has a quick onset of 2 to 5 minutes. And this one you're going to want to titrate every 5 to 15 minutes. So like I said, this is the most common medication within this class that we're going to use, but you may also come across two other medications, one called verapamil or another one called diltiazem or cardizem. Now, if you see a patient on a verapamil drip, it's typically not going to be continuous IV for hypertension, but rather for AFib. As well as for diltiazem, it's going to be the same thing. Diltiazem you'll see more often, and you're going to see this in the range of 5 to 15 milligrams per hour. All right, so now let's move on and talk about our direct-acting vasodilators. And there's just one medication that I want to talk about here, and this is one that we're probably all well familiar with, and it is a medication called hydralazine. Now, the interesting thing about hydralazine is we're not exactly sure how it works. There are different competing theories, but what we do know is it's actually selective for arterial vessel dilation and not venous. Typically, you're going to find this one given PO or IV push as opposed to a continuous infusion, but if you do see it being run as a continuous infusion, it's probably going to be related to secondary hypertension related to preeclampsia. If you are running it continuously, you'll find this in a mix of 60 milligrams and 60 mLs, or essentially a 1-to-1 ratio. And our dose for this one is going to be 1 to 10 milligrams per hour. All right, so now let's move on and talk about our nitrodilators. So now essentially these medications, what they're going to do is mimic the effects of endogenous nitric oxide. And this is going to be by either releasing nitric oxide or forming nitric oxide within the tissue. And as a result, nitric oxide actually causes smooth muscle relaxation. Now for this class, there's two main medications that we're going to talk about. The first one is called nitroglycerin, and the other one is called nitroprusside, also called Nitride. Now nitroglycerin is what we often call an organic nitrate. And the reason for this is because there's an enzyme that's going to convert it to nitric oxide. And nitroglycerin is almost exclusively selective for venous vessel dilation. Now this you're typically going to find in a glass bottle with a concentration of 50 milligrams and 250 mLs. And our typical dose is going to be anywhere from 5 to 300 micrograms per minute, although there really is no fixed max dose. It has an immediate onset, and we'll typically titrate this every 3 to 5 minutes. It's important to know, though, that after 12 to 24 hours that your patient may develop tolerance to this, and it may require a nitrate-free period. So now if we move on and talk about Nitride, that this one is actually going to spontaneously release nitric oxide. And just like with nitroglycerin, this one's almost exclusively selective for venous vessel dilation. So this one we're typically going to find in a concentration of 50 milligrams and 250 mLs. But there is a higher concentration that comes in 100 and 250 mLs. And our dose for Nitride is going to be anywhere from 0.1 to 10 micrograms per kilogram per minute, although it's rare to ever require a dose greater than 3. Now our onset is going to be 2 minutes, and this one we're going to titrate every 2 to 3 minutes. So really important thing to know about nitride is it's actually broken down by hemoglobin into cyanide. And typically this is going to be metabolized by the liver and excreted by the kidney, but in large continuous doses, the free cyanide may remain, leading to cyanide poisoning in your patient. And cyanide poisoning can limit the utilization of oxygen in our body, and so it's important that you're watching for an elevated lactate as well as an elevated mixed venous oxygen content. So very important to know this. All right, and so moving on to the last class I'm going to talk about here, and this is going to be our phosphodiesterase inhibitors. And basically this is often considered a backdoor approach to cardiac stimulation. And so the phosphodiesterase inhibitors actually inhibit an enzyme that breaks down our cyclic AMP, which has different effects in the heart and vessels. In the heart, it's going to increase contractility and heart rate, but in blood vessels, it actually causes smooth muscle relaxation both in arteries and veins. And the one medication that I want to talk about here is something that we call milrinone or Primacor. And this one's going to be primarily used in the treatment of heart failure and not hypertension. But again, it's good to know that it has these vasodilatory effects when you are using this medication. And this medication you're going to find anywhere in a range of 0.25 to 1 microgram per kilogram per minute. Again, I'm not going to talk about this medication much here because I am going to talk about it in a future lesson. All right, so that covers the mechanism of action classes that I wanted to cover for this lesson. The last thing I want to do is go over some good to know information, really some effects of these vasodilatory medications. So the first is that with this systemic vasodilation and decreased arterial pressure, that this can actually lead to a baroreceptor-mediated reflex stimulation of the heart. And so essentially what's happening here is the body's going to detect this decreased pressure, and as a result, it could lead to an increase in heart rate and contraction. So essentially these are compensation mechanisms trying to kick in. Now it's also important to know that these medications can impair the normal baroreceptor-mediated reflex vasoconstriction, most notably when your patient sits or stands up, and this can ultimately lead to orthostatic hypotension and syncope. You can also see things leading to renal retention of sodium and water, once again as a compensation mechanism that the body has for low blood pressure, and this would lead to an increase in the blood volume and ultimately cardiac output as the body tries to compensate for the decreased SVR. And finally, the last thing that I want to mention that it's important to keep an eye out for is something that we call pulmonary shunting. And this isn't something that you're going to see commonly, but what can happen is by dilating vessels that we can shift the flow of blood, which might normally be distributed throughout the lobes of the lung, causing more blood to go to one section of the lung over another. And so ultimately, if we have more blood going to that lobe, then it can actually supply an oxygen, that this can actually lead to a shunt effect. And so as a result, you can see hypoxia in your patients and see a decreasing saturation as a result of having these vasodilators. All right, so that is going to wrap up this lesson on vasodilators. We covered quite a bit talking about what exactly these medications are, some of the different ways in which these medications are classified, the primary way of being their mechanism of action, to which we then went through all the various different mechanisms of action and really covered the medications and the effects within a select few of these that you're typically going to see in your patients in the ICU. Finally, we rounded it out here with some basic good-to-know info, things to be aware of and to keep your eye on when you have patients on these medications. And so with that said, I do want to thank you guys so much for watching. I really hope that you found this lesson to be useful. I hope it had some good information there for you guys when it comes to being able to care for your patients in the ICU. If you did enjoy it and you did find it useful, make sure and hit that like button down below or leave us a comment and tell us what you thought. We always appreciate the feedback that you guys have. Make sure and check out the other lessons in this series, as well as take a look at the last series of lessons that we did covering the endocrine system. As always, thank you guys so much for watching, and you have a great day.